Hello and welcome to the finale of our campaign Beat Heart Failure, brought to you by the Times of India in association with Novartis. I'm your host, Paramita Chatterjee. The Times of India and Novartis made it its endeavor to create awareness and educate the masses about heart failure. They traversed across various cities around the country about a year ago, bringing cardiovascular experts and policymakers of various states to discuss and deliberate on the issue of heart failure. The first roundtable took place in Maharashtra, then Telangana, Rajasthan, then came the turn to meet with stakeholders in Odisha. From there it went to Madhya Pradesh, to the state of Kerala, Assam and Uttar Pradesh, and finally stopped in Karnataka.
The Health Ministry in Kerala is trying to tackle the problem of non-communicable diseases, not only heart failure but also cancer and hypertension and other things. We have already started. And our approach is to strengthening the government hospitals to have early detection on this NCD.
बेहतर से बेहतर स्वास्थ्य की सेवाएं मध्य प्रदेश के व्यक्ति को मिले, वो विशेषकर हार्ट के लोगों को हम किस प्रकार से उनकी बाधाओं को, उनकी समस्याओं को, उनको समय पर उपचार की जो सेवा, जो आवश्यकता हो, वो उपलब्ध कराने के लिए हम प्रयासरत थे, प्रयास करेंगे और प्रयास निरंतर ये हमारा जारी रहेगा।
एक्चुअली हमारा जो हेल्थ डिपार्टमेंट के अंदर हर एक गांव के अंदर जो सब सेंटर्स है, हमारा PSC से वहाँ पे हेल्थ प्रोफाइल के लिए जो सैंपल्स लेके जो तेलंगाना डायग्नोस्टिक सेंटर को जो अनुसंधान किया था, जो हैदराबाद में जो एस्टेब्लिश हुआ था, हर एक तेलंगाना जिलों में वो एस्टेब्लिशमेंट करके हेल्थ प्रोफाइल लेने के लिए हम सोच रहे हैं। इसके अंदर जो डिटेक्शन होता वो रेफरल हॉस्पिटल और टेरिशरी हॉस्पिटल केयर लेके कर सकता है।
In this disease there is two parts. One is precaution measure has to be taken and one is after the disease affected. So my government is particularly has a commitment that we will see that any suggestion will come in this occasion.
It is well known that lifestyle changes are increasing the burden of non-communicable diseases in our country, especially problems like diabetes and hypertension, which in turn significantly increase the risk of heart failure. I appreciate the Times of India's Beat Heart Failure initiative for educating citizens about the issues of heart failure. I have also been told that a simple tool has also been developed that lets people understand the symptoms and helps them as symptom checker. It is also important that citizens understand that heart failure is very different from heart attacks. The symptoms of heart failure are common, like frequent tiredness, breathlessness during routine activities and during sleep, and also the swelling of ankles, etc. These symptoms should not be ignored and people should consult their doctors in person or via teleconsultation in case they are having any such symptom. From government standpoint, we have been proactively leading the change at grassroots level. Population-based screening for common NCDs, including hypertension and diabetes, which are leading causes of heart diseases, has been rolled out throughout the country. Screening is also an integral part of service delivery under Ayushman Bharat Health and Wellness Center and is also an important component of government's strategy for early detection of diseases for their timely and effective management. Simultaneously, facilities for treatment are also being expanded. So far, 637 NCD clinics at the district level and 4,472 NCD clinics at community health center level have been set up under the national program for prevention and control of cancer, diabetes, cardiovascular diseases and stroke. Tertiary healthcare facilities are being expanded through setting up of new AIMS and upgradation of government medical colleges. I urge all health experts and policy makers to work collaboratively and collectively towards solutions to overcome the burden of diseases causing heart failure. I feel that in order to improve quality of life, we all should follow healthy lifestyle by healthy eating, including limited consumption of salt, avoiding stress, adequate physical activity, and exercising, including yoga and outdoor games, and avoiding consumption of tobacco and alcohol to prevent non-communicable diseases in general and also to beat heart failure.
Let's go straight across and introduce our panelists, beginning with Dr. D. Prabhakar, who is the Director at the Center for Control of Chronic Conditions, CCCC. Thank you so much, Doctor, for joining us. Dr. Ashok Seth, who is the Chairman at Fortis Escorts Heart Institute. Dr. Mahavir Singh, Chairman Cardiac Sciences at Max Hospital. Dr. Saibal Mukhopadhyay, who's HOD Cardiology at GB Pant Hospital. Professor Mohit Gupta, Cardiology also at the GB Pant Hospital. He's also the Secretary of the CSI, the Delhi chapter. Thank you so much, doctors, for joining us, and indeed we appreciate your taking time out of your busy schedule. Now, as I said, Delhi was supposed to be our last stop, and we have made a trip across the country and tried to bring about awareness in heart failure. Dr. Ashok Seth, let me start with you, because the biggest question we are always faced with is, when we are already talking about diabetes, hypertension, and cardiovascular disease, why is it important for us to focus on heart failure? What makes it unique or important for us to address this?
Heart failure, which you just described, and the heart starts to fail, is an end result of a number of disease processes which exist in us. For example, you've just said that heart attacks, there's diabetes, there's hypertension, there's obesity, there's smoking. All these lead to heart attacks. There's lipid disorders. And then, of course, there are other disorders like alcoholism, etc., which also leads to heart attack. And let's not forget the valvular disease, the rheumatic disease, which exists a lot in our community. But when we start understanding that it's an end result, we must understand that that means there are numerous people who are suffering from those. And by the way, heart failure gradually progresses through various stages to become an entity which is very difficult to manage, which practically, when it occurs, leads to death in 50% of the patient in the next 3 to 4 years. So while we may say coronary artery disease is the biggest cause of death, the number of people who exist with heart failure who are dying is immense. So unless we start focusing on them, unless we start actually predicting those who will go into heart failure, analyzing those who have structural diseases which may go into heart failure, and then creating policies around it, our focus will not be correct. The second aspect of creating policies around this is that there are many such issues which are actually policies can determine it. For example, smoking. For example, the path for valvular heart disease, for making sure that rheumatic heart disease is well recognized and then controlled on echo. Policy makers can determine a lot downstream, and unless their focus is downstream, we're not going to see the effects of upstream policies. The third aspect is that we've got to analyze all our policies are creating any results. So if we just saying that, but we're looking at diabetes, we're looking at hypertension, how do we know actually that it's bearing any results if we're not moving downstream and looking at the substrate, which is the end result as heart failure? So there are a number of reasons why we need to focus.
So clearly, Dr. Seth, I think you've explained to us the expanse, and it is a huge expanse. Essentially, many diseases eventually lead to heart failure. So, Dr. Mukhopadhyay, let me come to you. From a patient's perspective, one of the common myths that we faced in our campaign is that if I'm getting treatment for diabetes, for hypertension, and many of these chronic diseases, then perhaps I don't need to bother so much about heart failure. Are the two exclusive, or is it always mutually inclusive?
Common causes, if you look at heart failure, diabetes mellitus, hypertension, they are important factors which can cause heart failure. So if you are treating and the patient's target goals are achieved, that is, his hypertension is well under control, his diabetes is well under control, then he can be safely walking through that. He will not develop heart failure. But heart failure is multifactorial. It is not only diabetes and hypertension. It is not only the risk factors for coronary artery disease. There are many other diseases which can also present with symptoms of heart failure. So to make the people aware, we must first train them at what are the common symptoms of heart failure. And this is a crux, I think, that's important symptoms that patients and also the doctors must know is breathlessness. If a patient complains of having breathlessness on exertion, if a patient complains of increased fatigability.
On that note, let's head towards a short break. You're watching our special campaign, Beat Heart Failure, brought to you by the Times of India in association with Novartis. Welcome back to our special show, Beat Heart Failure, brought to you by the Times of India in association with Novartis.
Dr. Balbir Singh, what according to you are some of the biggest misconceptions when it comes to heart failure? For instance, it's often confused with a heart attack. Is that one of the biggest myths?
So, Paramita, there are a lot of misconceptions, not only this. The most important thing is that heart failure, I dislike this word because it gives you an idea and thought that the heart has failed. That means it is the end stage, which is not true. You could be in the early stage of heart failure and be treated and do very well with it. So people get a very big scare the moment you write a diagnosis of heart failure on their prescription. And I also hate writing that because you mean that the family has gone into a depression. So that point has to be taken that I write CHF or something like that so that the failure word doesn't come in. The second misconception is that all heart failures are bad. Now we have good drugs, we have much better methods of treating, so all stages can do better. The third misconception is that heart attack is same as heart failure, which it isn't. So both things are completely different. Heart attack has to be managed urgently, immediately, while heart failure is an OPD diagnosis and then patient gets worse, he may have to be admitted. So heart attack means the artery gets blocked and there is blood deprivation to some parts of the heart and the patient has been having chest pain, breathlessness and suddenly has to be rushed in. It is a diagnosis based out of ECG and some blood enzymes. Heart failure is a diagnosis based out of echocardiography, blood enzymes and clinical examination. So heart attack and heart failure have totally different meanings in the medical terms.
I'm going to take that point and go across to Professor Mohit Gupta. In India, we are seeing in terms of the profile of heart failure patients, as it's coming to the fore, it appears that the profile is of much younger patients, almost 10 years younger. Is there something in the Indian disposition or which makes us more predisposed to heart failure?
Definitely, there are 3 or 4 things that are working, and this particular population is known as the South Asian population. And what is happening is that the disease is occurring a decade earlier, number one. Second thing, the disease that is occurring is more severe. It is much more severe and much more virulent. And that is why, and there is definitely a genetic predisposition. There is a genome-wide study that is being now carried out, and there are certain analysis that have been carried out, and chips has been developed to see that what genes predispose us to early causation of coronary artery disease, particularly, which is one of the major factors contributing to heart failure. So, three factors are of real concern as far as we consider the Indian predisposition. One is that we are continuously having the aging population, the rising incidence of the coronary artery disease, and that too in a younger population, which is really worrisome. And then increase of all the additional factors like diabetes and hypertension. As you rightly mentioned, just the presence of diabetes be really worsening heart failure, and presence of heart failure worsening diabetes, and both are working in harmony with each other. So all these factors are a real concern, and that is why the prevalence that we are actually talking about today is much actually higher if we see in the world.
Let me come to Professor Prabhakaran, who's been waiting for us, because yours, sir, you were actually at the forefront of doing one of the earlier studies when it came to heart failure in India. What was it that you discovered in the course of some of your research?
So in terms of heart failure, I think the study that you're referring to is called the Inter-CHF study, and it was a multi-country study in which India participated, and we recruited close to 800 patients at that time. The thing that you mentioned that Indians were younger is true, and I think there's an additional reason apart from what Dr. Mohit Gupta said is the valvular heart disease also contributes to heart failure, and these occur in younger patients, and so the pool is somewhat younger. So you have valvular heart disease, you have a younger population, and you have higher prevalence of risk factors as well as early occurrence of coronary artery disease, which are all responsible for heart failure. That was the first point. The second point was India had the second highest mortality in the world after Africans. The mortality in that study was 23%, but subsequent to that there have been other registries such as the Trivandrum Heart Failure Registry and the current ongoing National Heart Failure Registry, which suggests that in hospitalized patients mortality can be as high as 30% at 1 year. In-hospital mortality is around 8%, which is pretty high. As compared to other population, our mortality rates are higher. And rightly you pointed out that it is because of late presentation. People come late in their natural history of the disease.
So Dr. Seth, let me come to you, because the fact is that we have a huge problem on our hands. But yet perhaps we don't have a single cohesive policy which addresses this particular issue. What do you think is the need of the hour?
A lot of conditions cause it. So you can imagine that the number of people who are affected by it is enormous, and it's a deadly disorder. 50% of these people are going to die within the next 3, 4 to 5 years. When we have that perspective, then it's very important to have a cohesive approach to them. So it's not just a matter of say, but I've been focusing at heart attacks or coronary artery disease, or I've just been focusing at some form of diabetes, or for that matter. It's because we have to not just focus on it, we've got to identify people much beforehand. We have to introduce medications at the right time to prevent deterioration. Those medications cannot be afforded by a lot of people. Right medications at the right time. There is advancements happening at every particular step, and therefore a cohesive policy about when to introduce what, which can be a burden both for the patient or for the exchequer or for the third party payer. And finally, advanced treatments for advanced heart failure, which still are known to prolong life but are fairly expensive. Now all these cannot happen unless there's a policy and there's a guideline oriented approach to these patients. So it is not just a matter of saying community based, it's a comprehensive policy which starts from the community to the clinician, down as it goes upstream to advanced centers and policy makers and third party payers, which actually have to be able to look after these patients. And the second most important point why we create policies, because many of these fall in the laps of policy makers and the administrators also.
So I think that's a really important point, that we need a cohesive policy. Professor Mohit, yes, please share your thoughts.
As Dr. Mukhopadhyay very rightly pointed out, there are 3 or 4 things that would be required in a cohesive policy. One is that awareness, both amongst the patients as well as the doctors. The second thing will be the proper detection methodologies. And detection methodologies can only happen when we have dedicated heart failure clinics. In fact, every center, like they are running hypertension clinics, they are running coronary clinics, they are running rheumatic clinics. It is a mandate that we should be spreading a message that every hospital, whether it's a healthcare center, it's a small hospital, government facility, should be having a dedicated heart failure clinic. Then we'll be able to recognize the patient. So awareness, detection, then the management, as Dr. Mukhopadhyay again pointed out, the proper methodology of treating them, giving them the proper medicines is very, very important. And the fourth important thing is to reinforce the cohesive policies, to report that patient.
Professor Prabhakaran, there is so much of data which is actually already being collected. We spoke to so many state governments. They are having health melas, they're collecting data. But where is that data going? Is it being used, or can it be used in a manner, even today, which can help us with heart failure, for instance?
So that brings us to a very important point, the point of surveillance. We need to keep a good count of what is happening, and unfortunately the surveillance system in our country is quite primitive, so we require to gather a very good health management information system, and I think there is some work going on. So for that we have to harness simple technologies and collect that data. You said there are lots of data that are available based on camp data and those kind of things. Those are not very useful really. It can give you a snapshot of what is happening, but it will not help in policy making.
Right. The other big lacuna is that when we are talking about heart failure, we don't really have numbers. You know, I mentioned at the outset between 80 lakh to 1 crore patients. But we have this big hole as far as the data is concerned. Why do you think that is, and what can be done to change it?
Right. So why is the data not available? One of the major reasons is diabetes. You just test a blood sugar and you know what is the prevalence or what is the incidence of diabetes. You check blood pressure and you know. But for heart failure, you have to make an effort to diagnose. But just this training to physician that you have a very simple test, NT-proBNP. Just do that blood test. You will distinguish many patients and you will get many patients. So presently, heart failure is diagnosed late. Many patients are not picked up. Echocardiography is not available universally. So that's why heart failure diagnosis is misled. And that's why we don't have registries, because majority of the patients are being treated in institutes which do not have echoes. So that's why you cannot diagnose heart failure. Patient has come with breathlessness, but how do you diagnose heart failure if you don't do the test?
Right. Let's talk about on-ground implementation. Dr. Mukhopadhyay, you know, does it need a policy, or are hospitals such as yourself working at an individual level and collecting that data?
The electronic system, telemedicine and telecommunication, it is in the pipeline. We are trying to develop it. Yes, we have systematically started.
Absolutely. I think those are very important points.
And, you know, just final comments. What would you advise in terms of actionable steps that can be taken from here on?
So the actionable step first is that at least 5-10 people of good minds in this specialty should write on national protocol that, look, if a patient comes to you with breathlessness, we need these 2 tests. NT-proBNP, echo, X-ray chest, 3 tests which should be done. If it is not possible in your institute, get it done somewhere. Then we have national-based registries, at least to the large hospitals. So wherever the patient may come from, it enters into the data. Suppose GP says that a patient came from Aligarh and was treated there. The data is entered. GP could refer him back to the physician in Aligarh, who can be asked that please do these follow-ups.
On that note, thank you so much, doctors, for joining us on this special show, Beat Heart Failure. We've got some critical solutions with us, raising awareness, using technology such as telemedicine, and making sure that patients get that early treatment. Thank you once again, and thank you to our viewers for being part of our special campaign, Beat Heart Failure, brought to you by Times of India in association with Novartis.